what we're going to do today, this is just a wrap up, and it's really just to sort of reiterate some themes, big ideas, and then hopefully have some chances for people to ask questions. It's sort of like what you were just doing with Sammy, like, what do we do here? How do you do this? Have you ever encountered it? And so on. So again, there'll be time for questions. We can put them in chat. So first of all, just some reminders. One, Medicare data are very powerful, but they're also very complex. And one of the pieces, no matter what your role is, to remember that most of the variables that we actually use need to be created. So as I worked with somebody a few years ago, and they said, I just want the variable for having a stroke in 2016. And we've been working together for quite a bit of time at this point. And I had to say, there is no variable. We have to create that. We have to create an algorithm. We have to decide who we're going to include, who we're going to exclude. We've got to do all of that stuff. So particularly if you're used to getting data sets that are relatively curated, the questions like you were asking Sammy, like, well, how do I clean this data? How do I decide how much messiness is too much messiness? The challenge is that's all ours. The positive is it means this is a much more flexible data set than we get. We can redefine, and two people can use the same data and use it in two very different ways, and that's good. But it does mean that that there's an awful lot of prep work that needs to be done, more than there is for an awful lot of other data sets. The data are complex, and I actually think and I work with a lot of people who like complex data, and they've had to admit these data are particular. So first of all, these are not rectangular files in the way they used to be. There are many, many files. So there are multiple one-to-many relationships to manage. So getting the data into a structure that you can analyze is not straightforward. And quite a few years ago, we did this exercise within our group of, we said, well, someone asked for standard code. And we said, well, let's code how to figure out whether something happened within 30 days of something else. And I was shocked because, again, I'm a really rusty Tarzan-y programmer, how many steps and how complex that was to actually do. But also we ended up with 3 different ways it could be done, but none of them were simple. It was not as simple as take this minus 30 if it's in this window, because of the relationship among the files. So just do be patient. Sometimes there are things that I think are easier to do by hand than they are to program with these data. Unfortunately, for the fact that there are 25 million of them, that would be the easier way to do it. So be patient and recognize the structure is complex. Also recognize that when we want to do 1-year follow-up, you necessarily have to use 2 years worth of data. So that means managing 2 years worth of data where the data file names are the same in both years. So again, there's going to be a lot of work, a lot of file manipulation work you need to do in order to get your data into a structure that's usable. The other thing I want to reiterate, and we will talk again about and repeat, CMS is required to make sure that rules are followed when releasing data. This means that the request is for minimum data necessary, so that's a HIPAA requirement, but they also do checks to sort of ask if they fill the request, could the study be done? And so what that is a belief that release for something that is not attainable is inappropriate release. So some of the questions you will get when asking for permission really have to do with, did you ask for more data than you need? And if we give you the data, can you actually accomplish what you say you want to do? And then finally, and again, this is on the list of mistakes that I've made in my career, don't forget that mistakes at the ordering phase are costly to remedy. So we often get to this place, I know I do, where I'm like, I just want the data, just give it to me. And you want to rush through those final checks and you're like, okay, fine, just sign it. And it can be costly in terms of money, but it also can be costly in terms of time, where people rush through steps because they don't want to be delayed. And then all of a sudden, when they're getting ready to cut the check or to make the payment, they read carefully and like, wait, this is wrong. And then we have to go through steps of approval. We may have to get things reapproved. We may have to get a new cost estimate. So in some cases, if you catch it before data are cut, it's just expensive. In other cases, depending on when you figure out you made a mistake, it can just really delay things. Or you have to do, as I one time had to do, which is you have to figure out how to make do with the thing you asked that wasn't exactly what in hindsight you wanted. So those are very real issues. And so definitely, as you've heard me say, these are not data sets for impatient people. But seriously, don't let this scare you away. There are things that we are able to answer. There are things we know about health and healthcare that we could not know without data sets like this. So this is the caveat, but what we know about geography and quality, racial variation, health over time, understanding the association between payment or other policy and healthcare use, many of those are only possible because we have large national data sets that track people from system to system and setting to setting. So these are things that we can only do. And I personally am grateful because I think our understanding of health, of healthcare, of what policies can be, would not be where it is without data sets such as these. So the pain truly is worth it. But do stop, first of all, and just confirm, like, are these really the right data for you? One of the places where people get caught up is they say, well, I know I can get Medicare data, and they don't always ask, well, is this really the right target population? So for example, Medicare, as you know, the bulk, 85% are older people. I get corrected every time I say elderly. But in fact, if we wanted to look at a condition where the incidence of interest is in people under age 65, it might not be right. So there have been a lot of studies recently about rising cancer incidence in people in their 40s. If we wanted to understand that and understand the relationship between that and Medicare, this would not be the right data set because we do not have population representation of people in their 40s. We do have some people who are disabled. We do have people with end-stage renal disease, but the bulk of our population is not in the target window. So as much as we would like to use it, this is a case where we'd really have to say, you know what, this isn't right for me. Other questions, can you identify your target population using information in Medicare and enrollment claims data? The one that continues to frustrate me, one of several, just so you know, is smoking. We have smoking, we have other exposures that are important, that are clearly related to health, that have that we would like to be able to track, but we cannot count on the coding in Medicare data or in any hospital data as a measure of it. So can we identify my target population? Can I identify cleanly a target population of smokers, or perhaps more importantly, a target population of non-smokers? I would have to say no. I would love to do it. I would love to have them, but I really can't. Can you identify your key outcome or explanatory variables using the information in the data? As an example, I want to find worsening heart failure, or I want to find cancer recurrence, or I want to find change in weight, or I want to find, there are many things that we can find in the data, and there are other things we cannot. So really stop and ask, is this likely to be best measured in a healthcare setting? Is it likely to result in care? And those are two of our biggest things that are going to help us figure out what is possible. And then the other question is, can you afford Medicare data? These data are not free. And they're still, as I said, they're still cost effective, but they are not free. So do take the time, we'll go over it in a minute, to look at the fee schedule. You should be able to come up with a pretty good estimate of what it's going to cost you and ask yourself, can I actually afford this? Does this fit with my budget? I am always surprised how often people will go through the process of creating a request. They'll fill out all the forms. They'll do, a couple months of work. And then we say, well, here's your cost estimate. And at that point, they say, wait, I thought these were free. They're from the government. So do take this step first and do understand the order of magnitude of what it will cost you to make sure that this really is optimal. CMS's philosophy about releasing RIF data for research is clear, and it is consistent. It is consistent for as long as I have been working with ResDAC, which is since 1998. Research is important and it is valuable. And so again, this is very much CMS sees researchers using the RIF data as a way to improve the health of the Medicare population and to improve the efficiency of the system itself. But they will not sacrifice beneficiary privacy in order to do that. So if there's a trade-off between knowledge and privacy, they will pick privacy. So if you get those questions, why can't you do this? That is their reason. That is their fundamental, consistent belief. And I cannot imagine that change. All use must comply with HIPAA. So this is a federal law. Medicare data are HIPAA covered. This is non-negotiable. Data are released to institutions, not to individuals. And this can be an issue in a couple of ways. So what it means is, for example, I'm now at the University of Florida. The Medicare data that I use is released to the University of Florida. It's associated with the project that I have, but it is not released to me personally. That means a couple of things. It means when I moved from the University of Minnesota to the University of Florida, I did not move the data. The data was released to one university, it stays with that university. New release is released to a new university. But it also means if there are situations of non-compliance, they are not personal non-compliance, they are institutional non-compliance. So it means that your institution has an interest in making sure that all users comply with CMS policies, because if all users don't, all users will be cut off. So you may hear this when we talk about data security, when we talk about who is the institutional signator, this is why. And release of data is always for a particular purpose, and all use must be approved by CMS. So it is not a situation where once you get it, you can do anything with it you want. Release of data is purpose specific, and you just have to ask if you want to use it for another reason. HIPAA is the Health Insurance Portability and Accountability Act. It's the national standards to protect sensitive patient health information from being disclosed, and it guides CMS release. It allows for the release of identifiable data for research. There's a research exemption. It lists 18 identifiers that must be protected, and some of those identifiers are protected by not allowing any release at all. CMS does not release names. They do not release social security numbers. They do not release addresses. They do not release medical record numbers for research, period. Under no circumstance is that done. Other elements, dates, they will release, but they expect the data to be kept secure. So the protection can be different for different identifiers. HIPAA also defines what a breach is. CMS doesn't define breach. The users don't define a breach. HIPAA defines a breach. And all HIPAA-defined breaches, which are unintentional disclosures or disclosures other than where it was intended to be disclosed for the purpose it was intended to be disclosed, have to be reported. It includes standards for use, and it requires documented institutional review board or privacy board approval. So when you get asked to show that you have IRB approval for your research, that is because that is a HIPAA standard. So again, people said, why do I have to show this? Why are you making me do it? And the reason is it is required by law. So those are just things that are not negotiable in CMS's perception. And I guess they could change, but I will say since the time I've been working with ResDAC, they never have. So one of the first questions that we have to do, because again, we are receiving the Medicare data under a research exception. The first question is this research? And there's a tighter definition of research here than some of us might do. So it's important that you know the purpose of research is to create generalizable knowledge. The knowledge that is generalizable must extend beyond the specific patients, admissions, records, providers being studied. So in other words, if I say, I want to know what happened in my clinic last October, that is not research. If I say, I want to know the impact of hurricanes on clinic function, and I'm going to use the hurricane that hit in October as an example, I will be allowed to do it. So in other words, it involves creating information about the association of variables with each other to answer questions about the role of, association with, etc. There must be a hypothesized association about things being measured. You can be wrong, but you have to have some expectation, not purely descriptive. So I can say, I suspect hurricanes disrupt healthcare, and that is okay. I might be wrong. I doubt I am, but that is a testable hypothesis. Interesting, technically, purely methods research doesn't qualify as research, methods development. So as an epidemiologist and as someone who likes these data, I've got to admit, candidly, this one always makes me a little sad. But what it means is that if we ask for the data, I don't just say, I want to develop an algorithm to identify, to create a computable phenotype. That's methods work. But then I would say, and I want to use it to examine the association of gender with the computable phenotype. So again, all it means is you can still do the methods work, but you just have to remember that the final step is to actually use the method. That is what would make it research. So you can propose methods development, but don't forget to say, and then I want to use the method I'm developing. So in other words, development of tools is secondary to the plan to use it to answer a question. Okay, so again, if you want to develop a tool, you also want to show that you're going to be using it as part of your request. Do consider, will you get the information you need? So yes, it is research. Can you get the information you need? You can get measures of demographic characteristics, healthcare use. You can, who provides the care, select assessments, payment information, and then stop and ask questions. We've given you a couple of examples. Did you confirm that there aren't other changes that will get in the way of your study? Coding changes are common. Payment changes, as Sammy just showed you, with the change of how home health is paid. And think about it in the case where we've got that one, we're layered on top of a change in how home health is paid. We also have a pandemic. We have more recently occasionally said, you know what, I'm going to stop my research in 2019 because I don't know if we have enough post-COVID data yet to understand to try to separate out the impacts of COVID and the impacts of other things. You can choose to do it, but just ask, what is that going to do? With the SEER cancer registries as another example, Hurricane Katrina so totally disrupted the healthcare system that when they report, they just blank out the Hurricane Katrina year. So again, you can do a variety of things. And I suspect during COVID, we will be seeing things because that is such a shock to the system that I think most of our ability to draw lines is going to be disrupted by that. So, but even still, confirm that there aren't other things that are going to get in the way. If there are, maybe you can find a way around them. We often can, but the worst thing we would do would be to not anticipate them and then to reach the wrong conclusion. Don't forget, ICD-10 codes are organized completely different than ICD-9. There's a larger number of codes, and personally, I think they're difficult. ICD-9, and maybe it's just because of when I learned ICD coding, they're in groups that are different. ICD-10, every digit has embedded meaning, which means that adjacent, sort of what I would consider like adjacent diagnoses may not actually be adjacent in ICD-10 land. To me, that's hard because it means it's a lot more work to scan a list of codes and find out if one is missing. The ICD-9, we could say 220.1, 220.2, 220.3. Okay, they're all there. With ICD-10, it's not going to be as linear of a test. So it means you're going to have to take more time and be more careful to make sure you don't miss a code. And as we've said, and I really want to emphasize it, the Medicare claims processing manuals are incredibly helpful. I know it seems like they're really odd, but they really will give you an awful lot of guidance into how the data are created, because ultimately the way they are created will affect how we can use them. The CCW has a sample size estimation tool. The tool allows you to construct simple searches of Medicare enrollment. So for example, if you want to look at something, you can say, well, how many of this procedure were there? And it will tell you. Now, if you've got further restrictions, you're going to kind of have to guess. You may have to do other adjustments. What it won't let you do is do a complex search. I can't say how many of this procedure among women who were 85 and older were there. So we can say, well, I know how many there were. I know what percentage of the population is women, and I know what percentage of the population is 85 and older, and I can do some guesses, some back of the envelope, but there is no sample size tool for super complex searches like that, even if that's ultimately what we need. There are CMS chart books, and there are also other external reports. Kaiser Family Foundation is one that I personally have found to be quite useful in terms of the number of reports they have and understanding trends, also understanding things changing over time. So if you've got a sample size estimate or you've got data from 1 year or a published article, they can help you do some sort of synthetic estimates of what you're likely to get. Just remember, you're going to need to balance minimum data with adequate sample size. And often we end up having to negotiate with ourselves as much as with CMS. So if there are two subjects, we say, I only have, there just aren't enough. Can you add extra years? Can you let your cohort accumulate longer? Can you relax your criteria? But the other question you should ask is, well, am I surprised by this? Like if we said, I want to study hip fractures and your estimate comes back that there were 11, you're like, that doesn't work. That doesn't seem right. Was it possible you made a mistake? Did you forget a code? Did you, but also look at cell size suppression policy. It talks about how small of a number you're allowed to report. So if you're looking at very, very small cases of things, you might not be able to publish them even if you wanted to. So do understand how that's going to limit what you end up doing and how you're able to show it. And in contrast, if you have way too many subjects and sample size comes back and you get an estimate that it's 25 million people, are you sure your assumptions are correct? If you don't need that many, can you use a sample? Can you do a 5% sample? Can you take a 10%, 20%? Can you restrict by some other factor? Say, well, really, I only care about people between 65 and 75. I don't need those older people. I'm not going to study them anyway. Can you do geography? If are you going to say, well, I really don't need the entire US. I'm going to take a sample of 8 states. Or can you do fewer years? I don't need to have my cohort accumulate for 4 years. I can let my cohort accumulate for 2 years. Or do you need all these years because you've got other assumptions you want to test? Like, is there a time trend? So just do think about, there are ways of increasing and controlling your sample size. And you may, depending on what your numbers come up, you may be asked to do them. So think in advance about how you can do that in a way that preserves what you want to do in the study. Now, in terms of the price, there are fee lists on the ResDAC website. This is a sample. This is a fee list, an example for the VRDC, which is the Virtual Data Research Center. And the user fees, they do change from time to time. The VRDC is right here, so you can see it. There are for the physical data. I think CMS is seriously considering their policy around physical release of data. So just keep an eye on it, but look at the ResDAC website, look at the fee list, and understand what it's going to cost to use the data. When you're doing data selection, remember, you can use a range of criteria for selecting your cohorts. You can do a percentage, you can do 5, 100, 20, you can do different percentages. You can select based on the presence of a diagnosis, a procedure, or a condition. You can select based on geography, either the beneficiary or the provider. My first use of Medicare data was, we had the Florida state segments. I was down at the University of Miami, and I used a geographic sample. You can do a selection based on demographics, and you can link to a cohort with a numeric ID. So you can use a variety of ways to select your cohort. When you create your cohort, it's really important to remember that you are both getting permission conceptually and you are actually providing directions. So Sometimes people will say, I mentioned this a couple of days ago, I want continuous enrollment. But in fact, what you need to say is, I want 2 years or until death. Because if you don't say that, when they're pulling the data, they will only pull 2 years. You might want to say other things. So again, be very clear on what your directions are, and make sure you know when you are providing directions for a pull and when you are describing broadly what you are doing. We've certainly seen a number of times where the specifics of what will be needed to do a data selection, the requester did not appreciate the importance of precision there. Personally, I would say be wary of selecting cases based on the CCW chronic condition variables only. I think they do, as I've said, they do what they do very well, but you want to make sure that you're not going to, by mistake, leave out some cases that you in fact probably want. So if you're going to use a CC chronic condition algorithm, you want to go in, look at that algorithm, double check that you understand the assumptions underlying that algorithm and that you agree with them for your particular study. As I've said before, think about how you're going to identify your population, your events, and your adjusting variables. Sounds really simple, but in fact, this is the step that takes the longest. So now a quick poll. What sort of data do you think you're going to want for your project? For your first or your next one, whichever it is. So this is actually unusual, I'll tell you. So it's very typical to have people wanting a sample of all beneficiaries. Clinical diagnostics are again really one of the key ways people use it. The linkage, a third of you, 30% of you are saying you plan on doing a linkage, and this is an unusual number. Linkages, I personally like. I think they're really important. They provide opportunity to extend the data. They also offer opportunity for methods work, which can then be used to use the data without a linkage. But there are extra steps with linkages. So we will get to some of them, but very definitely if you're going through the requesting process, do take time and know that it's a little bit longer than it might otherwise be for just a simple, 5% sample. Once you get the data, the first thing you should really do is double check everything. And it's hard because the volume is massive. They're in multiple files, but do take the time to double check. Does it seem like the size of files are about where I expect them to be? In my master Benny summary file, if I thought I was getting 1 million people, does that file have more or less 1 million records? Or does it have 11? Does it seem like I'm getting my segments? Do the data seem populated? Just spend a little bit of time just asking those basic things. Look at a few records to make sure, to confirm the world is acting the way you expect. And this is something when Steph said yesterday or the day before, looking at a few records, it doesn't mean printing them, but it does just sort of mean, like we did in our exercise, sort of saying, could I tell a story from this? Can I picture how this is happening? And make sure that it really does seem right. Do the numbers seem right? And because these files are right, when you do your analysis, don't forget there's both size of effect and statistical significance. And again, I personally have had to a number of times say, I'm not going to report straight p-values because the magnitudes are just crazy.